Hi friends, welcome to my channel Dr.Sreenivas Medical Concepts. I am Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we will talk about a topic which will be useful to doctors of all specialties, and that topic is pain. So, pain is such a useful topic that all doctors across specialties need to understand. Before I start off with the actual talk on pain, let me start off with an interesting and exciting example. Have you ever realized that when there's a pinprick or a prick because of a thorn, you have severe pain, and what do? Immediately you start shaking your hand like this, and it reduces your pain. So how does this happen? How does the shaking of your hand or rubbing on the painful area decrease your pain? I'll be talking about all these and other important concepts of pain in this lecture. So what is pain? Pain is an unpleasant sensation localized to a part of the body. So it's an unpleasant sensation localized to a particular part of the body. But very interesting to know is that pain has got dual qualities. It has got dualities. Most of us are aware that pain has got sensation. It's an unpleasant sensation. But what is very fascinating about pain is that it has got another component also, which is known as an emotional component. So pain has got dual characteristics. There's a duality to the pain. One sensation, two emotion. For example, a person who is raised in a very sophisticated environment will feel the pain discomfort a lot. But imagine a soldier or one who is a very hardworking person who is brought in difficult circumstances. He may not react to the pain with so much of discomfort. So though the pain sensation is the same, perhaps for both the persons I've just described, the reaction is different. The emotional component is different. This is because the spinothalamic tract, it carries the sensation of the pain up to thalamus, from thalamus to somatosensory cortex. But from thalamus, we have fibers going to the frontal cortex, the insula, as well as the cingulate gyrus, which are responsible for emotion. So what I want to stress here is that pain has got duality. One, sensations, two, emotions. So let's see about the pain in detail. As I said, pain has got duality, sensation and emotion. So basically we have, among sensations, we have three nerve fibers. One, the large sized fiber, which is known as A beta, which is well myelinated. It responds to touch and moving stimulus. This is very important. This is what I am going to explain in the gate control theory. So we have one, the large sized fibers, which is well myelinated, which is known as A beta fibers, which carry light touch and sensations from the moving part. And then second, we have two types of fibers, A delta and C fibers. A delta is mildly myelinated, C almost non-myelinated, unmyelinated, very small fibers. They are specific for pain perception. So they are known as nociceptors, pain carrying fibers. So we have these two fibers coming up. One goes to the posterior column, basically responsible for position joint vibration sense. The other goes to the spinothalamic tract, which is responsible for pain and temperature. Fine. So the spinothalamic tract, which is primarily responsible for pain and temperature, enters the dorsal root ganglia, enters the sensory part. From the spinal cord, it goes to the thalamus. From the thalamus, it goes to somatosensory cortex where the pain is appreciated, the sensation of the pain, but it also goes to the frontal cortex, cingulate gyrus, where the emotional aspects of the pain are perceived. Fine. This is the ascending pain transmission pathway. But we have a very good control at the level of the spinal cord. This is known as the gate control theory. What does this say? Not all pain sensations are transmitted through this pathway. You have another pathway, that is the large fibers coming on to the spinal cord, and therefore when the large fibers are stimulated, this closes the gate in the spinal cord and will not allow the pain sensations to be transmitted. This is known as closed gate. So when the large fibers are stimulated, as I said, the large fibers are responsible for touch and moving stimulus, and therefore when they are stimulated, it closes the gate and does not allow the pain sensation or impulses to be transmitted. That's the explanation for pain prick or any painful sensation in the thumb. When you get hurt, you immediately start doing like this. You immediately start moving the hand like this, because you are stimulating the large fibers, which closes the gate in the spinal cord and will not allow the pain impulses to be transmitted, closing the gate. This is known as a gate control theory. So we have a first level control at this particular level. Fine. We have another control at the higher level, which is coming from the hypothalamus, going to the midbrain, medulla, and coming to the spinal cord. These are known as pain modulating pathways. So one, we have the pain transmission pathways, which can be controlled by the gate, by large fibers. Second, the pain transmission, the spinothalamic tract, can be modified by the pain modulating pathway, which is a descending pathway coming from the hypothalamus, midbrain, medulla. This tract contains lot of opioid receptors. This tract contains lot of opioid receptors, and hence it is assumed that this tract gets stimulated, and opioids are most powerful analgesics. They immediately bring down the pain. So it's a pain modulatory pathway. So when this gets stimulated because of the opioid receptors, there's excess of opioids and it brings down the pain. This is a pain modulatory pathway. And therefore, when we, during acupuncture or just a placebo effect, just giving a tablet or working out a lot, stimulates enkephalins and endorphins, and they act on this pain modulatory pathway to bring down the pain. So just thinking that the pain is going to come down, or giving or taking a tablet given by a doctor saying that the pain is going to come down, the placebo effect will enhance the activity in the pain modulatory pathway and will bring down the pain. Very important. Second important point which I would like to tell is that we tend to assume that pain is produced because of injury and inflammation. It is not as that simple as we think, because how do you explain then the pain of migraine where there is no injury? Probably the migrainous pain acts through this pain modulatory pathway. As I said, the name is pain modulation. It may bring down pain on most circumstances, but may enhance pain also. So there are a lot of complexities in the transmission of pain and in the perception of the pain. One, it can be controlled at the level of the spinal cord itself, which is known as gate control theory. And second, the pain transmission not only transmits the sensation of the pain, but it goes to cingulate gyrus and insular cortex, which modifies the emotional response. 2. 3, there's a descending pain modulatory pathway which can bring down the pain. So there are a lot of interactions going on in the pain transmission pathway, and the final outcome will depend upon the type of interaction between these three pathways. Right. So as I said, the gate control theory, you have, whenever someone has got a prick because of the thorn, they immediately start shaking their hands. When you start shaking your hands, you are giving a moving stimulus. When you give a moving stimulus, it excites the large fibers which closes the gate in the spinal cord and will not allow the pain to be transmitted through the small fiber pathway. So this is closed gate and therefore pain will be inhibited. So this is known as gate control theory. So this is a wonderful explanation why we unknowingly, when there's a painful stimulus, we start moving our hands or keep rubbing. In one of the conferences, neurology conferences, one of the residents asked me why when our bladder is full and we don't get an appropriate place to void urine, we keep moving like this to control, and we to some extent control the urge. How is it possible? It is just a speculation. When large fibers by moving the hands can control the small fibers by closing the gate, likewise the moving body parts, especially our legs, perhaps in some unknown way closes the impulses which would want us to evacuate the bladder. This is just a speculation. Fine. Another few important concepts one need to understand is sensitization. What is sensitization? When there is an inflammation going on, it releases lots of substances. Especially from the clinical point of view, the important inflammatory mediators are prostaglandins. Why prostaglandins is very important? The non-steroidal anti-inflammatory drugs bring down the pain by inhibiting the production of prostaglandin, and therefore one of the important mediators of inflammation and pain is prostaglandin. Second substance P, bradykinin and leukotrienes. All these are important mediators of inflammation. So when there are a lot of mediators of inflammation, the threshold comes down and a stimulus which may not usually give rise to pain may start giving pain at a lower threshold level itself, at a lower level itself, when the intensity is at a lower level itself. So this is known as sensitization. So much so that an innocuous, a non-painful stimulus appear to be painful, what you call it as allodynia. So the inflammatory mediators are prostaglandins, P substance P, bradykinin, leukotrienes. Right. So this is the basic pathophysiology of pain. Given the complexity of the various interactions, the sensation, the intensity, quality and the duration of the pain on one hand and the emotional reaction to the pain on the other hand depends upon how you perceive the pain with the effect from all these three interactions. Right. Referred pain. What is this referred pain? Referred pain is the spatial displacement of the pain from the site of injury. For example, the diaphragm, it is supplied by C3, C4. Shoulder is also supplied by C3, C4, C5. Both will converge on the C3, C4. So the brain can get confused. When there is a diaphragmatic irritation, it may think that the pain is arising from the shoulder. So the spatial displacement of the pain to another area from the site of injury is called as the referred pain. The classic example is the pain referred to the shoulder from the diaphragm because both go to the C3, C4 level. Right. We have two other types of pain, the neuropathic pain and the sympathetic pain. The neuropathic pain is seen in the peripheral nerves, a lesion of which can cause a decrease in the perception of the pain, the impairment of the pain, or paradoxically can cause a dysfunction of these pathways and increase the pain. Classic example is herpes zoster or trigeminal neuralgia, where the lesion of the nerves can produce pain. And another important clinical point here is that they can spontaneously start producing pain, and it is presumed that there is a density of the sodium channels in these nerves which are not functioning well, non-functioning nerves. Because there is a density of the sodium channels, when the treatment would be to give a sodium channel blocker which will decrease this sodium channel density. The example being sodium channel blockers like phenytoin, carbamazepine, oxcarbazepine. That's how, though these are anti-epileptic drugs, They are useful in these painful conditions like herpes zoster, trigeminal neuralgia, because they are sodium channel blockers and block the density of the sodium channels which accumulate in the non-functioning or dysfunctional nerves. Another important point is the sympathetically mediated pain, what you call it as CRPS, complex regional pain syndrome. Here it is assumed that the nerves become hypersensitive to adrenergic substances, and therefore after injury, after a few days, there may be swelling of the pain with sympathetic dysfunction, and therefore when you give sympathetic blockers, the pain may come down. So we have two important types of pain, neuropathic pains and CRPS. Now let me talk about a very fascinating concept, the phantom limb pain. What is this phantom limb pain? To appreciate the abnormal, we need to appreciate the normal. We have the hand and the face area which has got the highest representation in the brain. The face area and the hand area which has got the highest representation in the brain. Point to point is a representation. As I said earlier, the representation of the body parts in the brain is not according to quantity, it is according to the quality. So the highest representation of the brain is for face and hands. So if the hand area is stimulated, the hand area of the brain gets stimulated, the face gets stimulated, the face area of the brain gets stimulated. Imagine, God forbid, there is a traumatic injury and the arm gets cut. So you develop a phantom limb, a non-existent limb. So what happens? In these persons, when the hand area, because eventually when the hand is cut off, the hand area and the brain also starts slowly disappearing and fading. But because of a very interesting concept, the neural plasticity, the face area starts enlarging, and now it starts occupying the hand area. So the face area has enlarged and encroached upon the hand area, which has disappeared because of the amputation of the limb. So now this entire area is a face area, which was once upon a time hand area. So now if you stimulate the face, person who has got phantom limb will think that his hand, which is non-existing, is getting stimulated, and he starts feeling pain in a non-existent part of his limb, which you call as phantom pains. So very interesting phenomenon. So what happens? These persons, they think that these phantom limbs are assuming unusual postures, twisting movements, which is causing pain. So these persons come to the doctor saying that my phantom limb is producing pain. So is there any way of bringing down the pain in these non-existing phantom limbs? There is a treatment known as mirror box treatment, which is well described. In this mirror box treatment, what they do is that they make a box with two holes. Imagine my right hand is amputated. I have a phantom limb on the right side. So they make a box with two holes, the center point being a mirror, centrally placed mirror. So it reflects the hand which is placed here. So I place by my normal limb in the left hole, my amputated limb on the right hole, but it does not enter because it is cut. So I just bring it to the place where there is a hole. In the mirror, it shows the reflection of my hand on the mirror. So when I do various kinds of movements, it appears on the mirror and the brain thinks my non-existent right hand is doing or performing these movements. And therefore now brain, these activities starts getting fired, and by using all kinds of maneuvers and releasing the abnormal postures, the phantom limb postures also the brain perceives to get relieved and the pain comes down. This is known as mirror box therapy for phantom limb pain, a superb, fantastic concept, well explained. Then let me talk about another important concept, headache. I told in my previous lecture that all the parts of the brain are not sensitive to pain. In fact, the most sensitive structures of the head to perceive pain are the meninges, the covering of the brain, and the vessels in the meninges. So, the important pain perceiving structures in the head are the meninges, the covering of the brain, and the vessels in the brain. Most of the brain is insensitive to pain. You cut brain, there is no pain. So, most of the conditions which affect brain do not produce headache. I repeat, most of the structures which affect brain do not produce headache. So, what are the diseases which produce headache? So, the answer is also simple. Those diseases which affect the meninges or the vessels in the meninges usually produce pain and headache. So, what are they? One is subarachnoid hemorrhage. Because the circle of Willis, the arteries are in the subarachnoid membrane. So, when the aneurysms rupture, they produce blood in the subarachnoid space. So, it is in the meninges. Meninges is a pain sensitive structure. So, subarachnoid hemorrhage characteristically produces headache. Second, meningitis. Again, it is an inflammation of the meninges. So, when the meninges get affected, they get headache. Some books say that intracerebral hemorrhage also can produce headache. But yeah, it is true. But when do these intracerebral hemorrhages produce headache? Intracerebral hemorrhages are more likely to produce cerebral edema and raised intracranial tension as compared to the ischemic strokes. So, because the intracerebral hemorrhage produces raised ICT because of cerebral edema, it goes and impinges on the meninges, and that's how intracerebral hemorrhage can produce headache. So, intracerebral hemorrhage can produce headache only when there is raised ICT, when there is cerebral edema, when it goes and impinges on the meninges. By and large, a brain lesion does not produce headache. Another important point about headache is migraine. Migraine also produces headache because of the trigeminal-vascular pathway. The vessels from the meninges come to the trigeminal nerve, goes to the pons and other areas, and that's how it produces headache. Again, here the pathophysiology is meningeal vessels transmitting the pain through the trigeminal nerve. So, whatever may be the disease, finally, if only the meninges and the vessels in the meninges get affected, then only person perceives pain. Right. Yeah. Another important concept is syringomyelia. Syringomyelia is dissociated sensory loss. Dissociated means going away, association means coming together. In syringomyelia, the spinothalamic tract gets affected because syringomyelia, the lesion is in the center of the spinal cord. When there is a lesion in the center of the spinal cord, neither the posterior columns nor the pyramidal tracts get affected because they cross at the level of the medulla oblongata. It is only the crossing spinothalamic tracts which get affected, and therefore sensations carried by spinothalamic tract gets affected. That is, pain and temperature are affected, but touch, position, joint, vibration sense are spared. So, very interesting. Generally, the easiest sensation to perceive is pain. Someone pinches me, I jump, but someone touches me, I may ignore. But here is a person who, if he keeps his hand in the burning fire, he does not appreciate the pain sensation, but someone touches him, he appreciates pain sensations. So, when you get that kind of history, it is almost confirmatory of syringomyelia, a syrinx in the spinal cord. So, syringomyelia produces dissociation of sensory loss. Pain and temperature are lost because of spinothalamic tract being affected, because it crosses through the spinal cord, and a cavity in the spinal cord will affect the spinothalamic tract, whereas sensations carried by posterior column are spared, that is, touch, position, joint, vibration sense are spared. Right. Coming to the treatment, in the acute form, as I said, while I was discussing in the earlier part of my lecture, that one of the strong inflammatory mediators of pain is prostaglandins, and therefore NSAIDs, aspirin and paracetamol, inhibit the cyclooxygenase enzymes which come from the arachidonic acid, and will therefore diminish the level of prostaglandins and thus bring down the pain. NSAIDs, paracetamol, aspirin. Second is opioids. As I said, there are a lot of opioid receptors, in fact endogenous opioid pathway in the pain modulating system. So they act through this pathway and bring down the pain. So if the prostaglandins are inhibited or opioids are stimulated, it decreases the pain. Here I repeat again, opioids are the strongest analgesic substances which bring down the pain. They are the most powerful substances to bring down the pain. For chronic pain, most of the time it is associated with stress, tension type headache. We give tricyclic antidepressants so as to bring down their depression level, which will enhance the pain. In fact, serotonin is also one of the important mediators of pain. So tricyclic antidepressants bring down the pain antidepressants. Second, we have anticonvulsants. As I was talking earlier, there's a density of sodium channels in the non-functional nerves, and therefore when you give sodium channel drugs, antiepileptic drugs like carbamazepine, oxcarbazepine or phenytoin, it will bring down the pain. And the third category is opioids, as I said, for it acts on the neural modulatory pathways. So this is in a nutshell an overview of pain. As I said, pain can be modulated at various levels. One, it not only goes to the somatosensory cortex where the sensations are felt, but it also goes to the cingulate gyrus, insula and frontal cortex where it can modify the pain perception. Second, the large fibers can act at the level of the spinal cord, close the gate and not allow the pain to be transmitted. Third, you have the neural modulatory pathway which can most of the time decrease pain sensations, but sometimes it can enhance the pain. Because of the complexity, the perception of pain depends upon the interaction of these pathways. I have enjoyed giving the lecture and I hope you have also enjoyed listening to my lecture. If you have liked my lecture, please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Facebook page, Dr. Sreenivas Concepts. Bye. Thank you.